So we're going to discuss the characterization of renal lesions with MR. And these are my disclosures. We have institutional research support from Philips Healthcare. So the goals on this talk are to review the indications for MR and the characterization of renal masses. I'm going to make emphasis on aspects of the protocol that allow you to characterize tissue and detect enhancement accurately. I will discuss the characterization of both cystic and solid renal masses, and then talk a little bit about the presurgical assessment of renal masses, what needs to be included in the report. So as always, when you have contraindications of ionated contrast or you have concerns about radiation, MR is a great alternative to CT and ultrasound. More generically, because of the superb soft tissue contrast of MR and the sensitivity to small amounts of gadolinium, MR really is a great technique to characterize renal masses. So basically any mass that we have that is incompletely characterized by ultrasound or CT, we use MR to try to give a more straight answer. However, because of our limitation in detecting calcifications, we don't use MR as the first test to study patients with hematuria. Our protocol starts with the coronal single-shot fast spin echo images in both coronal and axial plane. We do then chemical soft imaging, axial T1 in-phase and post-phase imaging. And then we acquire a series of 3D fat-saturated T1 spoil gradient echo images in the coronal and sagittal plane for each kidney. After administration of a single dose of gadolinium, and we do this on a body weight-based approach, we acquire our coronal images again dynamically, as you can see here, with a corticomedullary phase. There's a time to the arterial phase, and an early and late nephrographic phase. We then acquire again the sagittal images for each kidney, and we finish with axial delay during the excretory phase. The sagittal images are acquired, as I can show you here in this diagram, slicing the kidney longitudinally, independently in two different acquisitions, and those are very useful to look for the anatomy. We have moved away from standard T1 SPGR sequences. We now use Dixon-based techniques for all our dynamic images. They provide more homogeneous fat suppression routinely for these exams. The coronal T2 single-shot fast spin echo images are great to characterize cysts. Simple cysts will appear as homogeneously bright with a thin wall and no internal architecture. Anything else that you see on these images really requires contrast to be characterized. They're great also to detect and characterize septations. They're very motion insensitive, so you can actually assess the thickness of the septations very well, which is very important, as I'll discuss later. And also to assess the quality of the fluid, again, another important feature when you characterize renal masses. Chemical shift imaging is based on the fact that protons of fat and water process rotate along the magnetic field at a different velocity. So depending on the echo time that you use, you can look at this, listen to the signal from fat and water when these protons are pointing in the same direction, in phase, or when they're pointing in opposite direction or opposed phase. And when this happens, the signal in the voxel that contains both fat and water get canceled because of the opposed phase. And it's important to discuss the feature of fat characterization rather in MR in renal masses. Try to clarify what the nomenclature is here, because there's a lot of confusion in the literature. So first of all, if you consider subcutaneous fat, you can see that the signal really doesn't change that much because it's almost 100% fat. So the same thing is going to happen in angiomyolipoma. And by the way, the post-phase image is recognized easily by this India ink effect that you see at the interface between fat and water. But an angiomyolipoma that contains fat will have the same characteristics. It will be bright both on in-phase and a post-phase imaging because there's basically pure fat in the center, and an India ink effect at the interface between the mass and the water in the renal parenchyma on these opposed phase images. Now, in terms of the fat that you're going to see in a renal mass, people discuss different descriptors for this. I like to talk about bulk fat and intracellular fat, which I think is a little more precise than intravoxel or microscopic fat. I don't think those are necessarily good terms. Bulk fat really refers to adipocytes, is fatty tissue. And when that happens, when you have a voxel filled with bulk fat, about 100% of the tissue inside that voxel is going to be fat. When you have intracellular fat, you have liposomes and vacuoles filled with fat in the cytoplasm. So essentially what you have is a combination of fat and water. A percentage of the voxel is going to be composed by fat, and another percentage of the voxel is going to be composed by water. How this translates into MR images. Again, if you have just pure fat, it's going to be bright both on the E phase and opposed phase, but you're going to see an India ink effect around the fat at the interface between fat and water on the opposed phase images, and this is what you see when you have bulk fat in an angiomyolipoma. You can be certain when you see bulk fat in a mass that is an AML. If you only have water, there's no cancellation of the signal, intermediate signal, both in phase and opposed phase images. If you have coexistence of fat and water, then an opposed phase imaging, you're going to have cancellation of the signals from fat and water, and you're going to see drop in signal intensity on opposed phase images relative to in-phase imaging. And this is what happens when you have intracellular fat, like for example in a clear cell renal cell carcinoma. However, some AMLs have very small amounts of bulk fat, and the net effect is going to be the same. You're going to have both adipocytes and water in the same voxel. So you're going to have as well intermediate signal that drops on opposed phase imaging. So the conclusion here is that if you only see that on a renal mass, intermediate signal that drops on opposed phase imaging, you cannot distinguish a clear cell renal cell carcinoma from an AML. You can only make the diagnosis of AML when you see bulk fat. Here you have a couple of examples. On the in-phase imaging in this patient, you can see drop-off signal on the post phase. This other patient, also drop-off signal on the post phase. However, this was an AML. This was a clear cell carcinoma. Again, you cannot distinguish based only on the signal drop on the opposed phase images. And this chemical shift score or signal intensity index was proposed years ago, but we and other groups have shown again that based on this score comparing signal intensity on in-phase and opposed phase imaging, you cannot distinguish those two entities. It's complete overlap of the signal. Some have suggested a T2 ratio to distinguish these entities, and the T2 ratio is the T2 of the tumor divided by the T2 of the renal cortex. And in this study, they concluded that a T2 ratio of 0.9, a T2 ratio of 1 will be basically IS-10 signal of the renal mass and the renal cortex. So a 0.9 will separate AML from, with minimal fat from renal cell carcinoma. Well, that's not exactly true, because when we look at the subtypes, again, for clear cell carcinoma, that may be the case, but not for papillary tumors. So again, you can actually distinguish with a T2 ratio AML with minimal fat from clear cell carcinomas. But AMLs with minimal fat and papillary renal cell carcinomas have exactly the same T2 ratio. Now, in the same paper, they show this graph, which I think is a very elegant way to combine the T2 signal with the contrast enhancement characteristics. So they have this arterial delayed enhancement ratio, which is basically how much the tumor is enhancing in the arterial phase divided by how much is enhancing on the delayed phase. So if we use the T2 ratio, again, 1 will be IS-10, so lesions that are on the left side will be hypointense to the renal cortex. And then the contrast enhancement ratio here, which means if the lesions are up here, they enhance more on the arterial phase than on the delayed phase. Below will be a more progressive enhancement. And again, you can see that AMLs will be hyper-enhancing and dark on T2. Papillary tumors will be hypo-enhancing and progressively enhancing, actually, and dark on T2. So using those two characteristics, we can distinguish those two pretty well. And clear cells tend to be hyper-intense on T2. So a couple of examples, mass that is very obviously dark relative to the renal cortex. You don't have to do a T2 ratio. You can actually look at it and see, is it darker or not than the renal parenchyma? Certainly it is. There is a minimal amount of drop of signal on the chemical shift imaging. This is an AML with minimal fat. You can recommend a biopsy to confirm. In this other case, however, you can see a rim of signal intensity that disappears on the post-phase imaging, so there's no question that there is fat in this lesion. However, you have central necrosis, and AMLs don't tend to have central necrosis. So whenever you see that, you have to consider this is going to be a clear cell and to prove it otherwise. Another way to explore the presence of fat in a lesion is to use frequency-selective fat saturation techniques, which destroy the signal of fat by applying an RF pulse in this frequency of fat. And if the mass goes dark after applying the pulse, you can tell that this is fat as long as you don't change any other parameters in the sequence. And this is obviously an AML. You can also use Dixon-based techniques, and again, this has been discussed in other lectures. By using 2 echoes per TR, you can separate the signal of fat and water. You can actually subtract these 2 and get an opposed phase imaging, or add these 2 and get an in-phase image. And once again, if you see the bright signal on the fat-only reconstructed image, you can tell with confidence that this is an AML, this is bulk fat. Now, how about enhancement? On MR, the signal intensity is relative. It's not like CT. We don't have HASTE unit scale. So we have to use a different approach to determine if something is enhancing or not, because enhancement is the best predictor of neoplasm that we have on cross-sectional imaging. If a lesion is enhancing, you have to assume it's a neoplasm and to prove it otherwise. And as you can see here, this patient presented with perirenal hematoma, a spontaneous large hematoma, and you can already tell there is something in the center that is probably enhancing. And if we compare the signal intensity, it's been shown that if you have a 15% difference between the pre-contrast and post-contrast images at 2 minutes, you essentially have perfect sensitivity for the presence of enhancement. Another approach is to use subtraction imaging. You can generate this at the scanner by subtracting the post-contrast images minus the pre-contrast images. And just by looking at these images, you can tell that this lesion is enhancing, because you can compare to an internal control, tissues that you know that are not enhancing, like for example in this case the gallbladder contents and the hematoma around the kidney. So these are dark background signal, so this is gray, clearly brighter than the dark signal and the hematoma. This is an enhancing renal mass. And these subtraction techniques are pretty useful when you have hyperintense masses before you give contrast. After contrast, in this case, you see 2 lesions in the kidney. There's no way for us to tell which one is enhancing and which one is not. When you look at the pre-contrast images, you can tell that probably the lesion in the lower pole is not enhancing, since it's bright pre-contrast. But just by looking at the subtraction and looking at the lesion, you can tell the lesion turned black, so that's not enhancing, compared to the lesion at the top, which, although is darker than the kidney, is clearly gray, it's not black. So that's hypo-enhancing, but it's still enhancing, and that's indeed a papillary renal cell carcinoma. So again, just by looking at these images, you can assess the presence of enhancement very rapidly without having to do region of interest analysis and measuring signal intensity. These hyperdense cysts or hemorrhagic cysts are very problematic as incidentalomas or incidental findings in single-phase CTs. And one of the questions is, what do we do after we see one of these lesions? Do we let it go? Do we do follow-up imaging? And if you do follow-up, what are you going to do next? You can do a multiphasic CT, but that's a lot of radiation. Or you can choose to do an MRI. With hyperdense cysts, usually with ultrasound, it's rare that you're going to be able to clear them as cysts. We prefer to do an MR because in a single study, you can basically rule out neoplasm and stop the follow-up. So like in this case, for example, you can see that the lesion is hyperintense, pre-contrast, and then when you do the subtraction, it's completely black, you're done. This is a hemorrhagic cyst. And this takes us to the Bosniak classification, which just as a reminder, is a 5 category classification, 4 plus the 2F in the middle for follow-up. And this is based on CT data. More on CT experience rather than data, because Bosniak basically created this classification based on his experience. And what it does is basically give you a sense of the likelihood of a neoplasm based on the complexity of the cyst on CT or MR. Bosniak 1 is a simple cyst. Bosniak 2, you may have some thin septations. 2F is, again, a follow-up, is in between 2 and 3. 3, you're going to see minimally irregular or thickened septae or walls in the cyst, and at 4 you see frank enhancing tissue. And traditionally we have managed these lesions with surgery for Bosniak 3s and 4s, although we're moving much more toward active surveillance in lesions that we know for sure, or not for sure, but most likely they are actually neoplasms. So how applicable is the Bosniak classification to MR? So Gary Israel and Bosniak look at this, and they found that in almost 70 cases, about 20% of them are discordant, mainly because you're going to see more septations, increased thickness of the cyst wall or septae, or the different enhancement pattern on MR compared to CT. And overall, this resulted in about 7% change in management. Now, many of these change in, they get upgraded because we see more cysts on MR than we do on CT. But one question you may ask is, what do we do with the lesion where the CT shows nothing, the MR shows septations, but then post-contrast images you don't see absolutely any enhancement? Is this really an upgrade in the lesion? Do we have to worry about this? But it's possible that actually the MRI technique is too sensitive for the Bosniak classification. So we have to really base decisions on the presence of enhancement, not on the presence of a number of septae. On the other hand, we need to know also how sensitive MR is for neoplasm and how specific. We don't have really good data on that. We do know, though, that when we have clear nodularity on MR, even when it's small, you can be confident that this is going to be a neoplasm. And we showed this a few years ago, a small number of tumors, but these were all cases, cysts with known nodules on MR, and pretty much every one of them was a neoplasm. And these were small cysts, although the cysts were, small nodules, sorry, although the cysts were several centimeters in size. On average, about 70% of these nodules was less than a centimeter. So we're talking a millimeter nodules. And again, when you see a 5, 6, 7 millimeter nodule on a cyst, you can be confident that it's going to be a neoplasm. But that doesn't mean you need to rush to surgery. And there may be other imaging characteristics in renal mass that can help you make decisions about how to really triage those patients for the most optimal management. I want to discuss some of these features and divide this into cystic and solid masses. I won't be discussing infiltrating masses. Starting with cystic masses, typically you're going to see two flavors. One is the cyst that contains simple fluid, and by simple I mean fluid that looks like CSF, bright on T2 and homogeneous, and dark on T1. And then you're going to see a variable amount of nodules and septations, which are typically hypervascular on the post-contrast images. And almost invariably, these cysts with this phenotype are low-grade clear cells. And this is important because these are very low-grade malignancies, particularly when you have very small amounts of solid components like I showed you before. So you can follow these lesions over time and see if they clear themselves. So that's why really making the decision between a Bosniak IIF versus 3 is not necessarily that critical. You can still follow them in 6 months and see if they grow. This patient actually refused surgery for a while, and eventually we were pretty certain that this was a neoplasm, and she got resected. It was a low-grade clear cell, and she didn't have any problem afterwards. So again, the risk of metastasis in this particular phenotype is extremely low. A different category is papillary tumors. Those tend to have hyperintense fluid on T1, hemorrhagic fluid, and heterogeneous fluid on T2, very different appearance. And on post-contrast images, they're very well encapsulated. And post-contrast images, the solid components are going to be in the periphery of the cyst as these papillary projections, which can be better recognized on subtraction imaging, as you can see here. Recognizing this phenotype is important, and is particularly important on CT, because this is a mistake that I've seen a few times. When you do a region of interest analysis on a CT, pre and post-contrast, and you can see that the cyst is hyperdense before contrast, you know this is not a simple cyst. You see this is going to be, at the very least, a hemorrhagic cyst. So if you actually look for enhancement in the same area on post-contrast images, you won't detect enhancement because, again, papillary tumors have the solid component in the periphery of the cyst. So you want to interrogate the periphery of the cyst very carefully to see if there's an enhancement in those areas. Otherwise, you may actually miss a papillary cancer and consider that's a hemorrhagic cyst. How about solid masses? So we like to look first at the T2 characteristics in a solid mass. If the lesion is predominantly, these are again very heterogeneous, but if predominantly is hyperintense on T2, we tend to think of clear cell and oncocytomas. These tend to enhance very avidly. They may or not have necrosis, and they may have intracellular lipids. So a couple of examples of clear cells. These are, again, very vascular, post-contrast, predominantly bright on T2, but heterogeneous. That one has necrosis. If you can see a mass that is predominantly bright on T2 and hyperintense, hypervascular, and that has fat on chemical shift imaging, you can be pretty certain that this is a clear cell carcinoma. Okay? And this is important because you don't need to do a biopsy in these cases. That this is clearly a renal neoplasm, a malignant neoplasm. There are exceptions. Without fat, you can see a lesion that looks exactly the same, and that can be an oncocytoma. Those don't tend to have fat, but they can have the other characteristics can be exactly the same. So again, there is definitely an overlap between clear cell and oncocytomas. How about the enhancement characteristics? So this is something that we published a few years ago just to look at 3 time points with a standard clinical contrast enhanced protocol. And you can see that clear cell carcinomas enhance much more avidly than papillaries, and chromophobes are typically kind of in between. So when you compare to the renal cortex, clear cells tend to enhance about the same as the clear renal cortex. Papillaries about 20%, 20 to 30%. Chromophobes tend to be about 50% of the renal cortex. And we base this, as I'm going to show you in a diagram at the end, we use these thresholds to characterize these lesions. And if you have 84% change in signal intensity on the early phase, on the corticomedullary phase, you can distinguish clear cell from papillary carcinomas with about 99% diagnostic accuracy. If the lesion is dark on T2, hypointense, then we typically think of 4 main differential diagnoses: papillary renal cell carcinoma, chromophobe renal cell carcinoma, oncocytoma, and AML. Of course, there are, in the less than 1% category, there are other lesions that can look like that, lymphomas, metanophthic adenomas, different tumors that are rare. But these are the main diagnoses, and what's important here is you have 50-50 benign malignant disease. So when you have hypointense masses on T2, that's when the biopsy may actually be more effective. You may be able to avoid some surgeries in some of these patients. I showed you before that papillary tumors are cystic masses with papillary projections in the wall. Well, they evolve from a solid mass to a solid mass with internal hemorrhage to a frank cystic lesion with those papillary projections in the wall. Regardless of their status, where they are in terms of the evolution, they're always dark on T2. The viable portion of the tumor is dark on T2. Obviously, you have hemorrhage, it's not. But the viable portion is dark on T2, and they're always hypoenhancing relative to the renal parenchyma. So if you have dark signal on T2 in the viable portion and hypoenhancement, you have to think of papillary renal cell carcinoma as your favorite diagnosis. Other lesions are dark on T2 as well. I described the AML with minimal fat before, chromophobes, RCC as well, and oncocytomas can be dark on T2 or isointense to the renal parenchyma. The segmental enhancement inversion sign was described on CT years ago as very specific for oncocytoma. This sign describes areas in the mass that are hypervascular in the early phase and then wash out, and other areas that are hypoenhancing on the early phase and then catch up and become hyperdense on CT or hyperintense on MR on the delayed phase. However, Andy Rosenkranz from NYU has shown that there is overlap with findings in chromophobe RCC, and that's our experience as well. You cannot distinguish these 2 entities based on that finding. So to summarize the results, not the results, but actually our approach to these masses, for a solid mass, we look first at the T2. If the lesion is hyperintense on T2 relative to the kidney, again, predominantly hyperintense. If there is having enhancement, we think of clear cell, particularly when there is fat, or oncocytoma clear cell if we don't have fat. If the lesion has moderate enhancement, again, remember those thresholds, 25, 50%, 100%, we think more of oncocytoma and chromophobe RCC. Again, these are all surgical lesions. If the lesion is isointense on T2 and there's avid enhancement, we think of the same differential, not a specific findings. If there's moderate enhancement, it's still not very specific finding. I should mention that biopsies here are not very helpful because very few pathologists will entertain a definitive diagnosis of oncocytoma on a core biopsy. There's too much overlap. Basically every renal cell carcinoma can have oncocytic differentiation. So on a single biopsy, they don't tend to give that diagnosis. So a biopsy is not necessarily diagnostic in this scenario. If there's low enhancement, again, we think of papillary renal cell carcinoma. If the lesion is hypointense on T2 and avid enhancement, then we think of the AML with minimal fat. Rarely a clear cell can present as dark on T2. But that's when a biopsy is very useful. Pathologists can make this distinction. This will actually prevent patients from having unnecessary surgeries. And if there's low enhancement, then we favor papillary, but AMLs can sometimes present with this feature as well. So again, if it's hyperintension T2, that's where you want to really consider biopsy to avoid unnecessary surgeries. In terms of the pre-surgical evaluation, there are several things that you want to mention in your report. First of all, you want to describe the location of the mass and how exophytic it is in the kidney. It's important to describe this because the percentage of the mass that is exophytic is the best predictor of the need for intraoperative ultrasound. If the lesion is completely endophytic, the urologist won't be able to find that lesion intraoperatively, and depending on their degree of sophistication, some of them are very used to do intraoperative ultrasound, but in certain hospitals, the urologists require the help from radiologists with the intraoperative ultrasound, so you want to know if that's the case. The number of renal arteries is important. They have to clump those renal arteries to do a partial nephrectomy so they don't have bleeding during the surgery. So if you have accessory renal arteries, you want to mention those. If you have an anatomy of the renal vein that is not conventional, it's very important as well. So they don't have accidental damage of that renal vein and hematomas and bleed in the OR. You want to describe the presence of infrarenal aortic aneurysms, as sometimes they have to approach these lesions from the retroperitoneum, and they don't want to, again, damage the aorta. And of course, the presence of lymph nodes and adrenal and distal metastases have to be part of the report as well. If you have renal vein thrombus, you want to describe the level of extension of that thrombus. If it's in the renal vein, typically is considered approachable through the standard surgery, level 1. If it gets into the IVC, then you have to describe if it's below the inferior margin of the liver, or if it's intrahepatic, if it's gone inside the liver. In that case, typically we'll distinguish between below and above the hepatic veins, or if it has extent above the hepatic veins, then you want to be sure that there is not a level 4 thrombus which actually reaches the atrium. You don't have to remember these 1, 2, 3, 4. It is very important, however, that you describe where the tip of the thrombus is. If it's below the inferior margin of the liver, inside the liver, above or below the hepatic veins, if it's suprahepatic, if it has reached the right atrium or not. When it's inside the heart, those patients are typically put on bypass. Cardiothoracic surgery typically is involved in those surgical resections. Diffusion-weighted imaging, as you know, has gained a lot of interest in recent years for characterization of multiple different neoplasms, and renal cancer is not an exception. There are several papers looking at the use of diffusion in these lesions. It's been shown that as you go from Bosniak I, benign cyst, to Bosniak II, 2F, cystic RCCs, and solid RCCs, there is a tendency toward a lower ADC. Makes sense. You're going from a cystic lesion to a more solid lesion. However, there is substantial overlap between benign and malignant disease, as you can see here. Interestingly, AMLs have a very low ADC. AMLs with minimal fat have a very low ADC. In my experience, papillary tumors are basically at the same level. You can see very low ADCs as well in papillary tumors. So again, you can't distinguish those two based on the ADC alone. So in other words, it's still the role of diffusion in characterization of renal mass is still debatable. We use diffusion primarily to look for disease outside the kidney, metastases, and other lesions. In patients that can get contrast, you get another extra tissue contrast mechanism. So it's useful to have these sequences as well. These are the B-values that we use typically for our renal mass protocol, like we do for any other abdomen: 050, 400, and 800. So in conclusion, remember the threshold for determining and enhancing mass on MR, 15%. You saw on the slide there was actually 15 to 20. 15% will increase the sensitivity without decreasing the specificity. So that's the threshold that we use, 15% between the pre and post-contrast images. If you see bulk fat in a renal mass, in other words, you see areas that are bright on the in phase, that remain bright on the out phase with an India ink effect around it, and they get saturated by frequent selective fat saturation, or you can see them as bright signal on the fat-only image on your Dixon acquisition, then you can be confident that that's an AML, angiomyolipoma, benign lesion. If you see what you can call little fat, small amounts of fat, then two scenarios are possible. One, you can have an AML with minimal fat, so you have a mixture of small amounts of adipocytes and muscle cells. But in those cases, the mass typically is homogeneously dark on T2. That helps you distinguish AML with minimal fat from the clear cell RCC, which can also show small amounts of fat on the post-phase imaging, but those tend to be hyperintense on T2, and if you have cystic degeneration or necrosis, then you're more certain about it. And finally, there are some phenotypes on MR that are predictive of histology, like the papillary renal cell carcinoma with low signal on T2 and hypoenhancing. So with this, I would like to finish, and thank you very much for your attention.